Great, thank you. Sorry about that, and okay, now it's working. Get rid of that. Okay, so sorry about the delay, and I'll start with the slides. Chronic graft-versus-host disease is a multi-system fibroinflammatory process seen in 50 to 70% of the transplant patients. Organ damage caused by alloreactive T cells, B cells, and macrophages. It remains the most common cause of late non-relapse mortality. And we have seen increase in rate of incidence and severity of this disease in the last couple of decades. That's due to increased use of unrelated donor, BBSC graft, and the switch from bone marrow to peripheral blood, older patients, and more recent data showing even older donors, myeloablative regimen, and prior incidence of a-GVHD and HLA mismatch. All those factors have shown recently to increase the rate of GVHD. The slides I'm showing now is showing annual number of allogeneic and autologous transplant reported to CIBMTR from the United States. And as you can see here, consistent increase in the number of allogeneic transplants. And now number have passed 12,000 annually. So, and looking at the number of transplant by donor type, as you can see here in blue color, match-related donor transplant have been the largest group up until 2010, when match-unrelated donors start to grow and became the largest number of transplants in the current years. Similar trend we are seeing with more BBSC compared to bone marrow, and now it is reported around the rate of 10% only of the transplant using bone marrow grafts. In this paper, with all the groups that I've shown and all those risk factors, this paper shows the reflection. As you can see on the curve here, increase chronic graft-versus-host disease over the years. And later on, we'll show more details about that. And as we say, prevention is the better than cure. Those are some recent strategies shown to reduce the incidence and severity of chronic graft-versus-host disease. They all targeting removal of alloreactive T cells, either in vivo or ex vivo. In this slides, I'm showing graft-versus-host disease prophylaxis platform used in the last decade. And as we can see here, the green showing the rapid increase in the use of post-transplant cyclophosphamide due to the data emerging about the benefit in reducing both a-GVHD and chronic GVHD incidence and severity, regardless of the type of the donor. So now almost 30% of transplants are done based on a post-transplant cyclophosphamide platform. In this European study, we can see the difference in chronic graft-versus-host disease in patients receiving ATG versus no ATG in a randomized phase 3 fashion. In this paper, there was no increase in relapse or infection, while there was a subsequent paper from the American showing increase in relapse made that approach less favorable. In the CTN study 1703, which we have just published in New England Journal of Medicine, we showed with multi-center randomized fashion that GVHD is less when post-transplant cyclophosphamide is used in the reduced intensity conditioning and peripheral blood stem cell transplant. Short-term follow-up so far showing no increase in relapse in this approach. In the study, 430 patients were randomized blindly to either tacrolimus, methotrexate, or post-transplant cyclophosphamide and tacrolimus and MMF. Primary endpoint, as shown here on the curve, is GRIFS, graft-versus-host disease-free, relapse-free survival. And as you can see, significant improvement with post-transplant cyclophosphamide group. This is considered a new standard of care, at least in the United States now, in patients undergoing reduced intensity conditioning, peripheral blood stem cell transplant from a match donor. Other strategies to decrease the chronic graft-versus-host disease, including graft manipulation strategy. And as you can see here, those are different methods that allow us to remove the T cells ex vivo. In a CTN study published, I think, 10 years ago or so, more than that, 2 years ago, patients were randomized to 3 different approaches in a myeloablative conditioning in younger patients. Patients received CD34 depletion, bone marrow with post-transplant cyclophosphamide as a single agent, and tacrolimus methotrexate, what was thought to be the standard of care at that time. And as we can see here, even though all those approaches were equal in decreasing chronic graft-versus-host disease, overall survival was lower with patients receiving CD34 depletion, most likely due to infection and relapse, similar to what we've seen in ATG as well from the Dana-Farber study. Again, making this approach less favorable. Another approach is T-cell depletion of CD45RA, which is the naive T cells. And by removing the naive T cells, which are responsible for growing graft-versus-host disease, we are leaving memory cells that are important for fighting infection and relapse. Also, some of the other cells that are important, like NK cells, are left behind in the graft. And this study was shown here, showing excellent results, but in single-center approach, and need to be reproduced in multi-center study, especially in the setting of complicated graft manipulation process. Another recent advances that have been, a little more focused on recently in the last couple of ASH is the Tregs T-cons approach. And in this approach, Tregs are infused with CD34 depleted stem cells on day 0 for Tregs to be allowed to expand and to prevent GVHD. And then later in 2 days, T-cons, which is similar to the donor lymphocytes infusion, just regular T cells, are given on day 2 to allow prevention of infection and relapse. In this phase 1b/2 multi-center study, donors were 8 out of 8 matched with myeloablative regimen and showing excellent rate of GVHD again, allowing the company that sponsored that study to proceed with a phase 3 randomization against tacrolimus, which is supposed to be, which was thought to be a standard of care at that time. So now, how does the chronic graft-versus-host disease develop? We have 3 phases. Phase 1, as you can see in this cartoon, is characterized by tissue damage resulting in the translocation of bacteria and fungi, leading to the release of PAMPs and DAMPs. And those are pro-inflammatory substance. They activate multiple receptors, including, as you can see here on the left side, P2X7 and P2Y2, ST2TLR, and NOD-R. All of those substances lead to endothelial cell injury and inflammation, including antimal arthritis and loss of microvessels. This also will lead to platelet activation and von Willebrand factor release. All of this process will allow more inflammation to propagate. In phase 2, effector population, including adaptive system, including alloreactive B cells, T cells, They both are getting primed with antigen presentation and lead to expansion and polarization towards more effective, more effector cells as type 1, type 2, and type 17 helper. The activation will lead to multiple cytokine secretion, leading to more activation further. And at that time, conditioning induced damage to the thymic tissue also lead to decrease in the Tregs population. That is supposed to help with the peripheral tolerance, which is lost in this setting. In phase 3, which is the last phase of this process, activated macrophages will produce PDGFR and TGF-beta. Both lead to fibroblast activation, forming extracellular matrix and sclerotic phenotype. Now, at the same time, with the activated B cells, making by those BAF factors will produce pathogenic immunoglobulin, and those will be deposited further in the organs, causing more damage and fibrosis. So that's kind of like a summarize of this important paper on the pathophysiology of GVHD. Now, the diagnosis of chronic graft versus host disease was always based on the time before or after day 100. But the new consensus from NIH showed that this is mostly should be based on the clinical symptoms. We have diagnostic features, which is sufficient to diagnose GVHD, and distinctive feature, which is suggestive only for GVHD, as you can see on those two lists. With those graded together, an NIH severity score will be able to differentiate for us mild chronic GVHD, moderate, and severe. This is important for prognostication as well as treatment approaches. And once GVHD developed, we have 3 levels where we could interfere to either stop the progression of GVHD or make it milder. We have the level of alloreactive T cells, where we can see, as you can see on the left side, we've discussed how we can remove those T cells to prevent or decrease GVHD. And on the right side with orange box there, you can see how we can inhibit T cell signaling through different type of pathways. Second level will be alloreactive, before that, Tregs level, which we could adaptive transfer those cells when we are, purify them from different donors. That's one way to do it. Other way, on the right side, as you can see, we have techniques that spare Tregs, including sirolimus, Cellcept, Rox, and bortezomib. Or we could expand it in vivo, including ECP or low-dose IL-2. The last level of interference, which we can do for management for those patients, is B cell, alloreactive B cells. And this, we can use, a depletion process by CD19-directed therapy, or we could inhibit the B cell signaling by either BTK inhibitor or SEC inhibitor. So, corticosteroids have been, the cornerstone in treating GVHD with response rate close to 40–50%. Multiple attempts have been, over the years tried to add second agent for upfront setting and, trying to improve the response rates, but all failed, as you can see here. All of this leading to either corticosteroid refractoriness or dependency, and they have different definition for those. Beside all of that, as you will all know and aware of, the side effects of steroids and possibility of intolerance. And steroid refractory GVHD is really difficult disease. In management, there is no real consensus. As you can see here, NCCN have listed every single drug that you could have. But really, basically, recently, FDA has approved 3 drugs back-to-back based on decent evidence in this population. Starting by ibrutinib, it's a proton tyrosine kinase inhibitor, was approved for chronic graft-versus-host disease based on phase 1b/2 study in only 42 patients with steroid refractory GVHD. In this study, patients were selected based on erythematous rash or mouth. So very spiky type of, early inflamed GVHD type of approach. Patient received 420 milligram of the ibrutinib until progression or toxicities. And as you can see in this slide, best overall response was 67%, but with only 20% CR. Around 70% had sustained response for 20 weeks or more. No specific organ had better response, but as we said before, most of those patients had only skin and mouth. Safety and AEs reported on the study were similar to what we've seen in ibrutinib, including fatigue, some GI symptoms, and some bruising, rarely cardiac issues. This is the Rockstar study, which is a phase 2 study of belmosudil, where more advanced cases were included. As you can see here on the left side, 2 to 5 prior lines of therapy were allowed. Patients were randomized to 2 different doses, 200 milligram daily or 200 milligram twice a day, in a larger sample size of 120 patients. Best overall response was 76%, mostly partial response, and CR was only 5% and on the early endpoint. Median time to response was very short, 1.8, and you would see something on those patients with a median duration of response of 50 weeks, so longer than what we've seen in ibrutinib. And we have data here showing that there is a good high response rate in GI and joints, GVHD, while response rate in lung was modest at 25%. AE on this drug were mostly low-grade, fatigue, GI, LFTs, muscle spasms, but grade 3 and 4 were rare, in the range of 5 to 10, mostly pneumonia, hypertension, and hyperglycemia. Very important, I've seen patients with DKA, diabetes ketoacidosis, because of the drug. So that's one of the things that I've seen. AE were similar to both doses also. So increase in dose did not increase the side effects of the treatment. REACH3 is a study of 330 patients with the strongest evidence for this. Patients were older than 12 years old and had randomized to either ROX10 BID or best supportive care, or best available therapy, Overall response was 24 years, significant for ROX, around 50% compared to 25. Again, CR is expected in this population is low at 6.7, but I think with more time it went up to 12%. Well tolerated with the grade 3 or above only, showing in a bone marrow suppression. Infection, as we can see here, is similar on both arms. Some of the attempts also try to use those novel agents upfront to try again to improve response rate of steroid, and also in this attempt of adding ibrutinib to prednisone also failed in having any positive results. Those, again, novel agents are under investigation, and the list is too long, but I'm going to pick 2 only. Axatilimab is a anti-CSF1 antibody targeting macrophage infiltration and activation. Usually is this the last step before activation of fibroblast in a phase 1 to 2 single arm escalation and dose expansion. Real sick patients included in this study with multiple prior lines of therapy. Most of them received all the 3 agents that are approved. And we see really good overall response of 60%, very promising drug. Some GI, mouth, and eye, which are difficult site to manage with the GVHD. Patient actually, even in the lung, had multiple cases of response. Now they have a study comparing 3 doses to see which dose is the best for expansion. Baricitinib is another, a third or fourth, lost counting, of JAK inhibitor. It is again very promising with overall response close to 60% and seems to be more durable than what we see with other drugs. Beside the chronic graft-versus-host disease directed therapy, supportive care is very important in this population, as you all know. I'm just going to summarize that we have to be careful with vaccination, IVIG replacement, infection prophylaxis, social and emotional support, and a lot of physical therapy for lungs and joints. So to conclude here, features of chronic graft-versus-host disease is heterogeneous. One size does not fit all. Prevention is better than cure. Long-term morbidity and mortality is significant. And risk of disease should not really allow us to think that we could cause chronic graft-versus-host disease to decrease relapse, because that has been shown in multiple studies that this is not true. Way safety profile drug against patient-specific symptoms and disease characteristics in making treatment decision. And cost and insurance, in different countries are factor to consider. Majority of patients with moderate to severe this should be chronic graft-versus-host disease will need additional lines, and steroid will not be enough. And supportive care in this chronic illness is very important. Thank you.